Good afternoon, everyone. This is Dr. Aditi Shende, Assistant Professor in Department of Dermatology at Symbiosis Medical College for Women and SUHRC, Pune. Today, on the occasion of World Leprosy Day, we have organized a small lecture on leprosy to create awareness among general public and patients of leprosy. Leprosy is an infectious disease caused by the bacteria Mycobacterium leprae. It is derived from French word leper and from the Greek word lepros, which means scaly, referring to the scales that form on the skin. Alternative name of leprosy is Hansen's disease. In common languages, it is known with names like Kushtrog, Kushta, Tolune, and Daktapita. Shushruta Samhita has provided clinical description of leprosy. It is also described in osteoarchaeological remains found in India, and its references are also found in Bible under the name Zaret, which when translated into Greek is termed as lepra in the New Testament and then into leprosy in the current language. A Norwegian physician in 1873, Gerhard Armer Hansen, discovered Mycobacterium leprae, the bacteria that causes leprosy, and hence it is also known as Hansen's disease. Prevalence rate and annual new case detection rate of leprosy has come down in the past few years. While the country as a whole has eliminated leprosy, two states, Bihar and Chhattisgarh, are yet to achieve elimination. Leprosy is transmitted via various routes, like more commonly via air droplets, then through direct contact of damaged skin ulcers, nasal secretion, mucosa, and hair follicles. It is important to know that leprosy is not spread via physical contact like a handshake or a hug. Earlier, it was known that there is maternal-fetal transmission of leprosy via placenta, but now even a single dose of leprosy, even a single dose of rifampicin kills 99% organism, and the chance of fetus getting affected becomes almost nil. There are various myths associated with leprosy, like it is contagious, hereditary, it's a curse, incurable, affects only the poor people, related to eating some types of food. These myths are important to be broken as these lead to social stigma and discrimination of leprosy patients. Leprosy is the least infectious disease. Almost 95% of the general population has immunity to leprosy. It is not hereditary, it's not a curse. It is curable by multi-drug therapy, which is available freely in medical hospitals. Also, it is not related to eating certain kinds of food. Coming to clinical features of leprosy presents with hypopigment, light-colored, erythematous macules or patches which have loss of sensation on them. Apart from this, they also present with swelling or nodules over the face and earlobes, and nasal stuffiness and epistaxis. Patients also develop pain along the nerves, loss of eyebrows, numbness over the hands and feet, and painless trauma or burns on the hands and feet. Cardinal signs of leprosy includes anesthetic or hypoesthetic skin lesion, that is lesions which have loss of sensation, enlarged peripheral nerves, and presence of acid-fast bacilli in slit skin smear. If a patient has any of this, then clinicians should suspect leprosy and investigate the patient further. WHO has classified leprosy into two types, possy and multibacillary. Possy-bacillary are the ones which have lesser number of skin lesions, that is 1 to 5 lesion, only one nerve or no nerves are involved, and slit skin smear is negative at all sides. However, in multibacillary patients, more than 6 skin lesions are present, more than one nerve is thickened, and slit skin smear is positive. If it is positive, even if one side, then it is classified as multibacillary. Apart from this classification, depending on the type of skin lesions which are present and the immunity of the patient, leprosy is of various types. If the patient's immunity is good, patients develop tuberculoid type of leprosy or a borderline tuberculoid type of leprosy in which number of lesions are lesser. As the patient's immunity keeps on decreasing, number of skin lesions increase, and patients go towards borderline lepromatous pole or the lepromatous leprosy pole. Lepromatous leprosy presents with multiple symmetrical lesions and diffuse infiltration of the face. There are erythematous nodules over the eyes and palate, which also there is glove and stocking anesthesia, which lead to resorption of nails and distal phalanx and leg edema. If a patient of lepromatous leprosy remains untreated for a very long time, then they develop complications like resorption of fingertips, xerosis, sunken nose, lagophthalmos, trophic ulcer, foot jaw, claw hands, nerve abscess, dactylitis, Z-thumb deformity, and even clawing of toes. Coming on to diagnosis of leprosy. First of all, diagnosis of leprosy clinical examination is of utmost importance. Examination of the skin of the patient to look for any light colored or erythematous skin lesions with loss of sensation, sensory and motor examination, and palpation of peripheral nerves to look for any thickening. Lab investigations include slit skin smear, in which tissue is taken from the earlobes or the active lesion edge of the active lesion. Zn staining is done to look for acid-fast bacilli, and punch biopsy is taken from the active lesion. HNE staining is done to look for presence of granulomas. Once the diagnosis of leprosy is made, treatment is started. Treatment depends on the type of leprosy, whether it is paucibacillary or multibacillary. Paucibacillary treatment is for 6 months, while for multibacillary treatment duration is for 12 months. So paucibacillary kit is of green color, which comes off with a monthly dose of 2 capsules of rifampicin and 1 tablet of dapsone, and daily dose of 1 tablet of dapsone. Each blister pack contains treatment for 4 weeks. Multibacillary adult blister pack contains monthly dose of 2 capsules of rifampicin and 1 tablet of dapsone, and in addition to this, there are 3 capsules of clofazimine. Similarly, daily dose of 1 capsule of clofazimine and 1 tablet of dapsone. Full course of multibacillary is that of 12 blister packs. Similarly, for pediatric patients, there are blister packs of blue and orange color. This is a picture showing closer look of each blister packs. Common side effects which can develop with multi-drug therapy, especially with rifampicin, patient develop orange discoloration of urine. They can develop flu-like symptoms. With clofazimine, they can develop orange-brown discoloration of skin. And dapsone, they develop liver toxicity and anemia. These side effects are reversible after discontinuation of therapy. Coming on to rehabilitation in leprosy. This is important in patients who have developed deformity or who have eye involvement. So in patients who have eye involvement in form of lagophthalmos or corneal ulceration, self-care of eyes is of utmost importance. This includes daily inspection of eye in the mirror to look for any foreign body or redness, to avoid rubbing of eyes, to think and blink, as in such patients blink reflex is hampered. So it is important to think and blink and deliberately close the eyes at regular intervals. It is important to wear protective gloves or cover with a cloth and wash eyes with clean water at least twice daily. In patients who have developed glove and stocking anesthesia, daily inspection of redness of hands and feet for any redness, swelling, or tenderness is important, as these patients are prone to develop trophic ulcers. They should wear thick insulated gloves for handling hot objects. They should soak anesthetized areas in warm water for 30 minutes. Rub off hard skin with scraper stone followed by oil applications. In patients who have anesthesia on both the feet, they should wear appropriate footwear, which specialized footwear called microcellular footwear. It's a protective footwear which is designed with adjustable 4-foot straps to accommodate any swelling, edema, and dressings. This should be used. Similarly, various splints and grip aids are also available in patients who have developed deformity. All of these are readily available in any leprosy center. Self-care tips to be followed by patients at home include to not to walk barefoot, to take small steps while walking, use footwear with an MCR insole, to check footwear daily for nails or stones embedded in the soles, check the feet daily for localized areas of increased warmth and for tenderness or for any redness or swelling, as these are the signs of impending ulcer. Trim the toenails properly and regularly. Do not smoke or chew tobacco as they delay wound healing. So the key message from this lecture is that first of all, that leprosy is curable. It is caused by a bacterium and it is cured with multi-drug therapy which is available freely in all health facilities. Secondly, early symptoms of leprosy, it usually starts with patch with loss of sensation or numbness, and patients should consult healthcare worker or occurrence of any of those. Thirdly, disabilities related to leprosy can be prevented. Early detection with appropriate treatment helps prevention. Next, leprosy is treatable, and once on treatment, patient does not infect others. Hence, there is no need for segregation of leprosy patients. Persons affected by leprosy once on treatment need compassion and empathy, and discrimination of some such patients is inhuman. Again, I'm emphasizing the fact that this disease is caused by germs. It is not contagious. It is curable with MDT. Once the patient is on treatment, it will not spread the disease. Person affected by leprosy can lead a normal life during and after their treatment. It is also important for the patients to take medicines daily for the scheduled period of treatment to avoid any recurrences. Patients should visit medical health facility regularly in case of any problems or if he develops any new patches, and patients should follow the principle of self-care at home. Next, I would like to conclude this lecture with a quote by Baba Amte, who has worked the most in in the field of leprosy, is that joy is more infectious than leprosy. Thank you.